Hello everyone, welcome back to my channel Surgery Nuggets by Dr. Himashri. Today, let's proceed to part 2 of Gallstone disease. We are going to discuss acute cholecystitis. So what is acute cholecystitis? It is acute inflammation of gallbladder, usually resulting from blockage of the cystic duct. So it can be of two types, acute calculous cholecystitis or acute acalculous cholecystitis. The pathophysiology of Gallstone disease, Gallstone formation, I have already discussed in the previous part. So here I am giving just a brief overview of how the calculus causes inflammation of the GB. So here you can see this diagram. There is a big stone impacted in the GB neck. So this is a gallstone impacted in the Hartmann's pouch. Blockage. The gallbladder will distend due to the increased intraluminal pressure. So why the pressure inside the GB increases? There is continuous mucus production inside the GB. So the GB will distend and there is no passage. It is not flowing towards the cystic duct. So GB will distend. The edematous GB wall will cause ischemia of the blood vessels. Ultimately, it may lead to necrosis in few parts of the gallbladder and sometimes the GB may perforate. So this is clinical features. The most common symptom is sudden pain. Sudden pain in the right hypochondrium which radiates to the right shoulder or tip of the right scapula. This is very common. And what is the difference between acute cholecystitis and biliary colic? In acute cholecystitis, the pain will last for more than 6 hours. So pain will last for more than 6 hours. It is a constant type of pain. And this pain may be also associated with nausea and vomiting. Get that patient is having high temperature, fever is always present in acute cholecystitis. Patient may have tachycardia, tachypnea. Other associated symptoms are flatulent dyspepsia. Very important, flatulent dyspepsia. Food intolerance to fatty or spicy food is also seen in these kind of patients. Now coming to Murphy's sign. Murphy's sign I have mentioned in the last class also. So Murphy's sign is seen in case of acute cholecystitis. Here what happens if the physician presses the right hypochondrium. If we ask the patient to take deep inspiration and we press the right hypochondrium at the height of inspiration, when the GB will touch the finger of the examiner, patient will have a sudden catch in breath due to severe pain. Okay, that is called Murphy's sign. It is done in sitting position. If same examination done in supine position, that is called Moynihan's examination. You can find a lump over the right hypochondrium. In which cases you will find a lump? Lump is found in case of complications of acute cholecystitis, empyema GB or mucocele of GB. So if patient has developed mucocele of GB or empyema, that means the bile is now infected, empyema GB. In these two cases, you may find a tender, palpable GB on examination. Now coming to next sign, that is Boas sign. Boas sign means patient will have hyperesthesia starting from 9th to 11th rib. That is called Boas sign. Perforation peritonitis, patient may undergo sepsis because of perforation of the fundus of the GB. Then jaundice or gallstone ileus. So what is gallstone ileus? Sometimes the stone is so huge that it compresses the GB and also CBD. Stone may perforate and cause symptoms of intestinal obstruction. Okay, that is due to cholecystoenteric fistula. This condition is known as gallstone ileus, seen in case of Mirizi syndrome. Now here I have shown two pictures. Last class also I have shown these two pictures. The first one is how Murphy's sign is elicited. Can you see? The examiner is pressing over the right hypochondrium. See, pressing over the right hypochondrium, we ask the patient to take deep breathing at the height of inspiration. At the height of inspiration, patient will have a catch in breath because the inflamed GB will touch the finger of the examiner and patient will have severe pain. So this is Murphy's sign. The second diagram is same, but it is Moynihan's method. Moynihan's method. Okay. So Moynihan's method is done in supine position, and here with the help of the thumb we are pressing the right hypochondrium at the tip of cystitis. Now coming to the diagnostic criteria, how to diagnose acute cholecystitis. Guidelines given in 2018 to diagnose acute cholecystitis. So here we have three criteria. Number one is local signs of inflammation. So A is local sign of inflammation. Then we see the systemic signs of inflammation, and third one is the imaging. So out of these conditions, if A plus B is present, then we call it as a suspected case of acute cholecystitis. But with any one of these two, A plus B, with imaging, if X-ray finding is also suggestive of acute cholecystitis, then we call it a definite diagnosis. So what are local signs? Local signs of inflammation of GB are Murphy's sign. I have described Murphy's sign. Second is right upper quadrant mass or pain or tenderness. So any one of these two. Plus systemic sign. So what is systemic sign? Fever. I told you in acute cholecystitis, fever will always be present. Fever will almost always be present. Second is CRP elevation. CRP will be high, indicating ongoing inflammation, sepsis. And third is WBC elevation. So any one of A plus any one of B, A plus B is suspected case of acute cholecystitis. But if along with these two features, ultrasound also suggestive, then as ultrasound positive findings are also present, then we call it a definitive diagnosis. This table is for acute cholangitis. I'll discuss in next class. Now coming to the severity of acute cholecystitis, how we divide it into mild, moderate and severe. So grade 1 of acute cholecystitis or mild cholecystitis, what happens here? If acute cholecystitis present in healthy person, so if acute cholecystitis present in healthy person and there is no organ dysfunction and it is present in healthy person, it is known as mild acute cholecystitis. Means mild inflammatory changes in GB. So we can definitely go for cholecystectomy, which is safe and low risk. Grade 2 is called moderate cholecystitis. Moderate cholecystitis means I have mentioned here 4 criteria. So any one of these 4 criteria if present, then we call it as moderate cholecystitis. So what is criteria number 1? WBC count. If WBC count is more than 18,000 per millimeter cube. Second, there is a palpable tender mass. I have already told palpable tender mass in the right hypochondrium suggestive of mucocele or empyema. That means it is now a complicated case of acute cholecystitis. So this is moderate cholecystitis. Third is duration of symptom. If it is more than 72 hours, then we consider this case as moderate cholecystitis. Fourth one is there is marked in local inflammation. So what do you understand by marked local inflammation? It means there may be gangrenous changes in the GB wall. That is gangrenous cholecystitis. Second, surrounding GB, there may be pus formation, pericholecystic abscess, or it may spread to the liver also, hepatic abscess. Sometimes because of perforation, we may get signs of peritonitis like rigidity. This is called biliary peritonitis. And emphysematous cholecystitis also another complication. Emphysematous cholecystitis. Now we have gas in the biliary tree, gas in the GB. So what is the investigation here? We'll go for CECT. CCT is investigation of choice for emphysematous cholecystitis. Third one is grade 3. Grade 3 also known as severe cholecystitis, severe acute cholecystitis. Here what happens? There is dysfunction of any one organ or system. That failure can occur in severe cholecystitis. First one is cardiovascular dysfunction. So what happens if patient is having hypotension? So in CVS, patient will have hypotension and may require patient may require dopamine. Okay, dopamine more than 5 microgram per kg per minute. Or if he requires epinephrine. If he requires epinephrine, any dose of epinephrine, we consider that patient is grade 3 cholecystitis. Second is neurological. What are the neurological symptoms? Decreased level of consciousness. So here consciousness is decreased level of consciousness. Third is respiratory failure. How will you assess respiratory failure? We look for PaO2 and FiO2 ratio. If it is less than 300, then we say that this is a case of severe cholecystitis. Fourth one is renal failure. So how do you assess renal failure? Means clinically patient will have oliguria. Okay, patient will have oliguria and creatinine level we check. So patient will have oliguria and create level is more than 2 milligram per deciliter. More than 2 milligram per deciliter. So this is the creatinine level. Next, hepatic dysfunction. Hepatic dysfunction is indicated by increased PTINR level. So increased PTINR level more than 1.5. Next is hematological dysfunction. Here we look for platelet count. If platelet count is less than 1 lakh per millimeter cube, then we call as hematological dysfunction. So these are the criteria for severe acute cholecystitis. Next, coming to the rare variety, that is acute acalculous cholecystitis. These cases seen in critically ill patient, in case of burn patient, parasitic infestation, or patient who are on total parenteral nutrition for a long duration of time. So these are some cases where we can see acalculous cholecystitis. So what is pathophysiology of acute cholecystitis? Basically, acute acalculous cholecystitis is due to cholestasis, that is bile stasis. Bile where we don't see any stone, there is no stone, but due to cholestasis and GB wall edema. Symptoms are symptoms of cholecystitis. Symptoms of cholecystitis are present here. Okay. Now, how to diagnose a case of acute cholecystitis? The diagnosis for all the Gallstone disease I mentioned in last class also. So here again a brief overview. So first investigation is always ultrasound abdomen. So ultrasound abdomen is the first investigation for Gallstone disease. Ultrasound abdomen, what we see here in USG, we can see presence of stone. Then we can see the GB wall thickness and edema. If it is more than 3 mm, so if it is more than 3 mm thickness, then it is called as thickened GB wall. Then we can look for the entire biliary tree. Okay, we can see the CBD. Is there any presence of stone in the CBD? Cystic duct diameter, CBD diameter. Okay, then liver also, liver and intrahepatic biliary radical. Intrahepatic biliary radical also we can see. Pericholecystic collection. Pericholecystic collection. These are some of the important signs that we see in ultrasound abdomen. Also, if a stone is present, if a gallstone is present, in last part also I showed you a picture. If stone is present, then in ultrasound we can see acoustic shadowing. Due to the stone, we can see a acoustic shadowing. Okay. Next to another important investigation, HIDA scan. So what is HIDA scan? Hepatobiliary immunodiacetic acid scan is a functional assessment. So HIDA scan is for functional. HIDA scan is for functional assessment of GB. Functional assessment of GB. So if there is cholecystitis, GB stasis, GB is not properly functioning, then that can be seen in HIDA. Within 30 minutes of injecting the radioactive dye, we should see the biliary tree and the GB. So if we don't see the gallbladder even after 30 minutes, that means some functional abnormality is present in the GB. Okay, so that is HIDA scan. Now blood investigation. What blood investigation we do? uh, the routine blood investigation to look for the WBC count. Okay, look for the WBC count and also CRP level. Okay, CRP level. Then we look for liver function test, PTINR. These are some of the important investigation, some of the basic investigation that we do. Also for severe cholecystitis, look for create level, serum electrolyte level. These are also important to assess status of the patient. Now coming to MRCP, if we are suspecting any stone in the CBD, then we can definitely go for MRCP also. MRCP is only for diagnostic purpose, whereas ERCP for diagnostic as well as for therapeutic purpose, where we can remove the stone in CBD. Now let's talk about the treatment part. So what we do for mild acute cholecystitis, as we have already, definitely go for emergency laparoscopic cholecystectomy after stabilizing the patient. So in first what we do, we keep the patient NPO, give the supportive management. Okay, keep the patient NPO, give supportive management. That means IV fluid, broad spectrum antibiotic and all. After that, go for emergency laparoscopic cholecystectomy. For moderate moderate to approach, first of all, definitely we keep the patient NPO and all the supportive care. That means antibiotic, IV fluid, resuscitation, everything we do. After that, if the patient is improving, then we can go for lap cholecystectomy. In advanced center. If it is an advanced laparoscopic center, we can definitely go for laparoscopic cholecystectomy. But if the patient is worsening or status is constant, then we should consider conservative approach. We should consider management conservative management, and then after 4 to 6 weeks, go for interval cholecystectomy. So this is for moderate cholecystitis. Then for severe acute cholecystitis means there is organ failure. So for organ failure, surgery is difficult. So what we do ultrasound guided cholecystostomy. That means we make a hole in the GB and remove the infected bile as soon as possible. So this is ultrasound guided cholecystostomy. Then we send the bile for culture sensitivity. send a bile for culture sensitivity, and after stabilizing the patient, we can go for interval cholecystectomy. So this is the management protocol for cholecystitis. So last topic is complications of acute cholecystitis. First one is definitely sepsis. There may be GB perforation. There may be GB perforation peritonitis also. So sepsis is one of the most important causes, most important complications. Second is Gallstone ileus. I mentioned already, Gallstone ileus is the condition where the big stone perforate the GB and there is a cholecystoenteric fistula. The symptoms of this case is similar to intestinal obstruction. Next complication is mucocele and empyema. In both these conditions, I told you there is a tender palpable GB. Tender palpable GB in the right upper quadrant, and mucocele is when the bile is not infected, but if it gets infected it is called empyema. Next complication is pancreatitis. Sometimes the stone may dislodge and block the main pancreatic duct, leading to pancreatitis. Another complication is pericholecystic abscess. So these are the complications for acute. These are some of the important complications following acute cholecystitis. Thank you so much. This much for today. We'll see you next video where we are going to discuss cholangitis. Till then, stay tuned. Please like, subscribe to my channel and share for more such videos. Thank you.